Okay, hello and welcome everybody, and thanks for joining. I'm so delighted today to serve as an opening act for this absolutely exciting ISSM webinar on regenerative andrology, dealing with erectile dysfunction and Peyronie disease. And just to note that this is going to be the last webinar of the ISSM series this year, as we prepare for the big meeting in December 15th in Dubai for the ISSM and Middle East Society of Sexual Medicine Society meeting over there. So please stay with us and as we prepare for that meeting, for this meeting, and also for the upcoming series next year as well. So my name is Dr. Omer Raheem. I'm a urologist at the University of Chicago, and I'm also the ISSM Webinar Series Chair. I'm very excited today with the extreme pleasure to introduce the topic today. And I think we're going to hear from esteemed faculty and moderation questions and answers on what's new on regenerative andrology in terms of erectile dysfunction and Peyronie disease. So please stay tuned and ask questions. I'd like to also remind the audience and the listeners that we are now offering subtitles and translations services. So please use this to change your chosen language by using this function here, which is called show captions, and you'll be able to hear and see the translation as you choose to do so through this function. Next slide. I'd like to remind everybody that ISSM has been around for several decades. And our vision is that we treat every human being has a right to be healthy and satisfying sexual life. Next slide. We've been around since 1982, so almost like 42 years ago. We founded, and the whole idea is that we want to cover the whole aspects and fields of human sexuality, which include male, female, transgender, and all important topics of sexual health. As you see from the map here, we have several societies that work with us. Each society is very active, involved in sexual medicine, providing really high level of education materials to the providers and health providers and patients as well. We work very closely with them. The ISSM has been coordinating and acting as a forum for these societies to provide a platform for their patients and their doctors as well. The ISSM really does this through different ways. I mean, today webinar is one of the virtual platforms that has been very popular since COVID. So we provide discussions, high-level topics to the audience, to the providers and patients and doctors through this platform. And like, for example, today webinar. But also we have a very important scientific platform. The Journal of Sexual Medicine has been the flagship journal, providing high-level scientific articles pertaining to sexual medicine. But also we have the open access sexual medicine, and also we have the sexual medicine reviews, which has been really one of the highest impact factors among all the journals of sexual medicine, again, providing really high-level reviews pertaining to sexual medicine and to both patients and also doctors. And lastly, we have the newly revamped Journal of Sexual Medicine, or Video Journal of Sexual Medicine, formerly Video Journal of Prosthetic Urology, and the leadership of Dr. Yafi as editorial chair. Now we are revamping the journal to provide, again, high-level surgical videos pertaining to training and skills that pertain to surgeons who perform sexual medicine techniques and procedures. Next slide. So today, I'd like to welcome Dr. Ege Can Serefoglu, Professor of Urology at Brno University in Istanbul. He's a friend and colleague, very active in the field of sexual medicine at level of ISSM and globally. With his moderation, we're going to listen to his faculty and esteemed faculty today and speakers. I'm sure we're going to have a wonderful discussions, and I'm looking forward to the discussion and Q&A session as well. So without further ado, I'd like to turn over to Dr. Serefoglu and to introduce his speakers.
Dear Dr. Raheem, thank you so much for this most welcoming invitation and this very kind introduction. And welcome everyone to this webinar, which is going to be on regenerative andrology, and which will be focusing on these types of regenerative therapies on erectile dysfunction and Peyronie disease. Those topics are very hot topics, and they are becoming more and more popular in the recent years. And in this webinar, we will not only discuss recent data and outcomes, but we will also highlight some of the newest advancements and nuances of low intensity shockwave therapy, PRP, stem cells, RF therapy, and many, many others. The first speaker is one of the biggest experts in this field. He has done many, many studies on shockwave, and recently published paper. His recently published paper was on PRP. Thomas Masterson from University of Miami. Tom, the stage is yours.
All right. Thank you very much for that introduction. So I'm Dr. Thomas Masterson from the University of Miami Desai-Seti Urology Institute. Thank you to the ISSM for putting my name out there and inviting me to speak today on restorative and regenerative therapies for erectile dysfunction. Next slide. These are my disclosures. Next slide. So restorative therapies for erectile dysfunction generally focus on three topics. This is shockwave therapy, platelet-rich plasma, and stem cell therapy. So we'll begin our discussion on shockwave therapy. Next slide. So first and foremost, let's define what a shockwave is. We as urologists are very familiar with shockwave as a treatment for stone disease. These shockwaves are high-intensity disturbances that actually propagate through tissue. When we're talking about treatment of erectile dysfunction, we're talking about shockwaves delivering or propagating through penile tissue. Now, these actually travel faster than the speed of sound, so they are not a sound wave. They are characterized by a very rapid rise in pulse pressure over a short duration of time. In stone disease, we're focusing them on a singular point, and that's what leads to fracturing of a stone. When talking about erectile dysfunction, we're delivering these waves over a much larger surface area. Next slide. So I'd like to take a moment to compare a shock wave to something else called a radial pressure wave. Radial pressure waves, at least in the United States, are offered under the name of Gaines wave as well as others, and these are not the same thing. Radial pressure waves have maximum pressures that are 100 times lower and are delivered over a duration of about 1,000 times longer. So these are not actually delivering the same energy into tissues. So these devices, at least in the United States, are regulated quite differently than a shockwave machine. Radial pressure waves are considered a Class 1 device, and this is essentially where things like crutches and Band-Aids and things that really can't cause direct harm to patients fall under. And that's why really anybody can offer those therapies. Next slide. So thank goodness we actually have a study from the Journal of Sexual Medicine that came out now 2 years ago that compared these radial pressure waves to placebo. And the authors of this study showed that there was no difference between placebo and these pressure waves. So now we have good conclusive evidence showing that these devices really don't do much. Next slide. Now I'd like to compare this to actual shockwave devices. And now much of what I talk about in this talk is going to refer to how things are regulated in the United States. Depending on where you are, they're likely regulated differently. But in the United States, all of the shockwave generators are considered a Class 2 device, which means they are regulated and can potentially cause harm to patients. Now, looking at them, they come, back a slide. Looking at these devices, you can see they come in all sorts of shapes and sizes. And the reason for this is none of these are actually approved in the United States for the treatment of erectile dysfunction. They have indications for other things such as plantar fasciitis, or revascularization of cardiac tissue. So all of them are used off-label. So you can look at the probes and see that they likely are placed in different areas. Here at the University of Miami, we have experience with the Direx device from Israel. You can see that's the probe intended for delivery to the penis. Next slide. So what do we think is happening in the penis? Well, the truth is there's never been a biological, mechanical study looking at it in human penises, but we do have studies out of rats proving some of these theories. So we believe what's happening is that the shock wave is delivering energy, which is causing tissue damage. And this tissue damage can recruit the immune cells to initiate wound healing, as well as recruit stem cells, both locally and from afar, initiate nerve repair, and possibly even restore normal endothelial signaling. So taken together, it sounds like these may be a good treatment for ED. Next slide. So there are lots of studies out there. You know, shockwave has been around for a long time, and fortunately we have enough data to do robust meta-analysis. And the most recent one was in the journal, the American Journal of Men's Health. They looked at 16 studies that compared shockwave to placebo and compiled them. This was over 1,000 patients treated. And in their follow-up at 3 months, there was a mean improvement in IIEF score of about 3 points. So that is pretty good. We have some improvement, but most importantly, there was almost no side effects related to shockwave therapy. So here we have a therapy that seems to have some benefit with almost no side effect. Next slide. But how do we interpret the data of individual studies? It is difficult to compare them all. And the reason for this is significant heterogeneity. So just some variables to think about is what shockwave generator was used, what probe were they using, and where were they delivering to the shocks? Is it to the perineum? Is it to the penis? The number of shocks being delivered at what energy and at what frequency? What patient population were they looking at? Was this mild to moderate ED? Was this post-prostatectomy? Is this patients who are diabetic? What are the treatment timelines? How many treatments were they getting in a week, in a month, in a year? And then what are their follow-up schedules? Did they look at them from 1 month, 2 months, 3 months? And were they using IIEF scores, penile hardness, penile Doppler studies? Next slide. But what do the guidelines say about this? Well, comparing the European to the American guidelines, the European guidelines have actually incorporated shockwave therapy as an option for men with vasculogenic ED. And you can use shockwave with or without the addition of PDE5 inhibitors. Meanwhile, the AUA guidelines still say that shockwave should be considered investigational and experimental, though who knows, this may change in the near future. Next slide. So moving on, we'll now talk about platelet-rich plasma, or PRP. So platelet-rich plasma is an autologous blood product that's created through centrifugation and separation of a platelet-rich layer. When you take that whole red blood or that whole blood product and spin it, you get 3 layers: platelet-poor, platelet-rich, and then the red blood cell layer. It's that platelet-rich layer that we're focusing on. And it contains a higher number of platelets compared to whole blood, and with that, an increased number of growth factors and cytokines. Now, platelet-rich plasma is not a new therapy. It's been used in orthopedics for a very long time, and we'll take this moment to talk about its regulation. So, platelet-rich plasma itself is not a drug, and it's not really a product. You're taking somebody's blood and giving it back to them. In the United States, because we are only minimally manipulating this product, it doesn't really get classified by the FDA as anything. It's not a drug, and therefore it doesn't fall under strict regulation. However, the centrifuges that create the PRP, they are again a class 2 device. They are indicated for the creation of platelet-rich plasma intended for orthopedic use and for preparation of bone graft. So again, we're using this off-label, but it falls into a gray zone. So people, or I should say physicians, have been using platelet-rich plasma in the field of urology probably for the past 10 years, despite there not really being any trials. Next slide. Fortunately, 2021, we had our first prospective trial. This was a prospective single-arm investigation looking at 3 injections of PRP 15 days apart. And the authors saw an increase in IIEF scores from 18 to 20 out to 6 months. However, there was no placebo group. Takeaway from the study, we saw some benefit and surprisingly almost no side effects. Next trial also came out shortly after that, same year. This was a randomized trial. 60 patients were to receive either 2 injections of PRP or placebo. And the authors here saw that 69% of patients in the treatment group had a minimally clinically important difference in IIEF score compared to only 30% in placebo. And again, almost no side effects. So early studies showing some benefit. Next slide. The largest study came out in the Gold Journal, and this was actually 100 patients randomly receive platelet-rich plasma or placebo. And again, they saw about 70% of patients improved in erectile function compared to only 20% in the placebo group. So again, good data showing that we may actually have some benefit. Next slide. So we at the University of Miami performed our own trial. This was a prospective double-blind placebo-controlled study looking at 2 injections of PRP compared to placebo. We had about 30 patients in each arm, and we specifically chose to use the Arthrex Angel centrifuge system. The reason we chose this is it is the only system, at least in the US market, that uses an optical sensor to try to create a uniform product to inject back into the patients. Next slide. Now, in our study, we did not see any difference between placebo or PRP. Now, there were some differences in the protocol with our study. We did 2 injections 1 month apart compared to the others that have done either 3 or 2 injections closer. We used a different centrifuge. We also used a different patient population in that we allowed patients to stay on their PDE5s at the same dose in both groups. So a little bit disappointing from our end. We were really hoping to see the same trend of benefit. But again, a takeaway from our study was that we saw almost no complications in either the treatment or placebo group. Next slide. So what are the problems? Again, similar to with Shockwave, there's really no standardization at this point. We don't know what volume of PRP we should be injecting. The studies, including ours, didn't report on the platelet concentrations, nor did we do any sort of growth factor analysis throughout the study. And another variable is leukocyte concentration. We chose to use a leukocyte-rich product. And then how many injections should we be doing? What timing should there be? And how do we activate them? Activation basically meaning, platelets contain the cytokines and growth factors within them. There are different methods to get the platelets to release those growth factors. Some use temperature, others use calcium chloride, but again, variability in how we accomplish it. Next slide. So we'll take a quick look at the guidelines. What do the European guidelines say? Well, they say the PRP should still be only used in a clinical trial setting. And this is the same as with the AUA, still considered experimental. Next slide. So lastly, we'll move on to stem cell therapy. Next slide. So first, what are stem cells? These are cells that have 3 distinct properties. They have self-renewal, the potential to proliferate extensively, and then the ability to develop into multiple cell lineages. Now, sources of adult mesenchymal stem cells are bone marrow aspirate, adipose tissue, and lastly, umbilical cord. Next slide. Once you have that substance, right, the bone marrow, the adipose tissue, you have to then separate out the stem cells. And there are 3 main ways to go about this. The first is centrifugation, much like the PRP. And then the other 2 are culture enrichment, where you grow out the stem cells, and the last is through activated cell sorting. Now, quick note on regulation. If you do centrifugation, this is considered minimal manipulation and therefore is unregulated. Once you do culture enrichment or cell sorting, now you venture into an area where there is strict regulation in the United States. So the majority of studies investigating stem cells are using centrifugation as the method of separating out the stem cells. Next slide. So how do we think stem cells are working? Again, no studies done in human tissues, but in animal models, there are two main ways that stem cells work. The first is through direct replacement of the corpus cavernosum tissue, and this is what we call the building block theory, where the stem cells actually rebuild those tissues. And the second is that these stem cells provide support by releasing cytokines and then drawing in other immune cells, or the paracrine theory. So taken together, we believe this is how they can potentially repair human penis. Take care. All right, next slide. So what does the data show? Well, we have about 10 studies out there looking at stem cells. The majority of these are single-arm, open-label trials. However, when you compile all the data, there's less than 100 patients actually studied, and all of them do report some benefit. Just like the previous topics, significant heterogeneity. Where did they get the stem cells from? Where were they injecting? How much? And what was the follow-up? Next slide. So where we're left, what do the guidelines say? Well, the European guidelines, interestingly, they mention stem cells as possibly beneficial, but really don't make any strong comments about it. Whereas the American guidelines say very strictly, stem cell therapy should still be considered investigational. So of the three topics, this has the least data to support it at this time. Next slide. So what does the future hold? Well, I anticipate that we will see more studies investigating stem cells and platelet-rich plasma. We at the university were fortunate enough to actually get an NIH-funded grant. Dr. Ranjith Ramasamy at the University of Miami is the PI for the project, where we're now actually looking at combination therapy of shockwave and platelet-rich plasma together, again, in those patients with mild to moderate erectile dysfunction. And we hope to be presenting this data within the next 12 months. Next slide. So again, I thank you for your time and listening. Thank you to the SMSNA and ISSM for allowing me to talk today. And we will take questions at the end. Thank you.
You're on mute.
Thank you very much for this beautiful presentation, Thomas. And the next speaker is Thiago from Brazil. And meanwhile, thank you for your lovely messages. Please do not forget to write your messages to the Q&A sessions, Q&A box, which will be, all of them will be answered at the end of this session. Thiago, the floor is yours.
Thank you very much. So good morning from Brazil. My name is Dr. Thiago Lima, and I was offered the opportunity to present regenerative therapies for Peyronie disease. But before I start, I would like to thank the ISSM for the invitation, also Dr. Serefoglu for the kind presentation, and also Dr. Omer Raheem for the opportunity to be here. Next. So I have no disclosures for this presentation. Next. Just a little bit of background. So Peyronie disease is a benign inflammatory disease of the penis caused by abnormal deposition of type 1 and type 3 collagen and fibronectin, which results in the formation of plaques, and it will cause penile shortening, curvature, and painful erections. Peyronie disease is currently managed clinically with injections, penile traction, vacuum therapy, some pills, or surgically when the plaque is stable. Regenerative therapies have emerged, focusing on developing new strategies to repair or recreate tissue. So based on these principles, numerous strategies have been proposed to be used as therapy for Peyronie disease. Next. So we have a lot of common therapies that Tom mentioned before, but I'll start here with shockwave therapy. Next. So as Tom mentioned before, the shockwaves, they will cause disruption of endothelium and the activation of stem cells and the release of VEGF that will cause increase in angiogenesis. But additionally, for Peyronie's disease, it can disrupt the collagen structure, promoting the breakdown of plaques and remodeling. It will also stimulate the release of other growth factors and cytokines within the penis tissue, and will culminate with the destruction and reabsorption of plaques. Here in Brazil, I do have some experience with the MedSpec machine, and I had a little bit of experience with the Direx back in the US, but we do have a lot of machines available for the treatment. And as Tom mentioned before, they are FDA Class 2 devices, so they should be done in the office with the proper physician. And as Tom mentioned before, because of the different applications for the machine, they are actually not approved for the use at the penis, and we actually use it off-label. Next. So just a little catch-up, as we see here in the graphic, the shockwave is characterized by a rapid rise in the pressure over a very short period of time. And this is a very important characteristic for the tissue penetration and for the depth of the wave. Next. So currently, both the AUA and the EAU guidelines only support shockwave therapy as an alternative to pain control for patients with Peyronie's disease. There is no evidence that it could have any effect on the curvature. Next. So I have a compilation of trials here, and those trials were conducted to evaluate the efficacy of shockwave therapy on Peyronie's disease. All of the mentioned studies here studied patients with stable plaques, and they had variable follow-ups up to 2 years with different machines. They use shockwave protocols of 1 session every week for 4 to 6 weeks. And in results, only pain reduction was significant between groups in the majority of studies. So there is no effect on curvature, plaque size reduction, and therefore it could be only recommended for the pain reduction. Next. Following the next therapy, we are going to talk about platelet-rich plasma next, which is commonly known as PRP. So as Tom mentioned before, the PRP is produced from autologous blood, and it has elevated concentration of platelet-rich plasma fluid. And PRP can be very accessible because it can be drawn from the patient and done in an office procedure. And it can be easily replicated in other facilities. And the platelets can secrete various cytokines that will mediate inflammation and stimulate an immune response to promote wound healing. Additionally, PRP is hypothesized to aid in the repair of Peyronie's disease plaques by the downstream of collagenase action. Next. So once PRP is separated from the rest of the blood, it can be injected into injured tissues. And we usually use the intralesional injections and tunneling as we do with collagenase injections. And so platelets, once they are injected, they are activated and then start degranulation. And they will secrete many products, as listed here in the slides, that are responsible for collagen synthesis, collagenase secretion, angiogenesis, vascular smooth cell recruitment, proliferation and differentiation, and the migration and proliferation of endothelial cells. And this will work towards an anti-inflammatory condition and reabsorb the plaques. Next slide, please. So I summarized the most recent data that we have here. So most studies here evaluating PRP efficacy for the management of Peyronie's disease had patients with stable plaques and showed important improvement in curvature. Dr. Virak conducted 2 studies in 2014 and 17 combining PRP with hyaluronic acid and showed significant plaque reduction and curvature improvement that vary between 30 to 39% in both studies. Dr. Notzek, in the end of the table, in 2019, presented a study comparing patients that received PRP with patients that received saline injection. So these patients that received PRP presented with significant improvement of curvature and plaque size reduction when they were compared with saline injection after only 1 injection. Next slide, please. Dr. Ashraf in 2022 also conducted a prospective study to evaluate the effects of repeated PRP injections for the treatment of Peyronie disease. 65 men received an average 6 injections over the period of 9 months. They observed after 12 months a 17-degree reduction of curvature and pain improvement. So reduction of curvature very similar to collagenase injections. Dr. Ramasamy, my mentor, is doing a clinical trial at the University of Miami comparing PRP injections with saline. In the last published update about this study, 14 patients were treated, and the preliminary 3 months result showed a 10-degree reduction in curvature and an improvement of PDQ questionnaire. So most protocols here include multiple injections and variable volumes of PRP, as Tom mentioned before. This could get in the way of our analysis. Involving more injections may have higher curvature reduction. Next, please. So next therapy, is hyaluronic acid. So hyaluronic acid is usually not discussed as regenerative therapy, but some of the proposed mechanisms of action are very similar to the other therapies. Therefore, I included it here for discussion. So just a little background of hyaluronic acid. It is a glycosamine glycan, and it maintains hydration, turgor, plasticity, and viscosity in the amorphous connective tissue. It is commonly used in aesthetic procedures, and more recently has been used in urologic patients for penile enhancement procedures. So Ege, how does it work? The Ege injections may inhibit TGF-beta signaling pathway and modulate fibrosis formation. Can also cause tissue hydration, which improve tissue flexibility and reduce the stiffness associated with the fibrous plaques. Also, Ege can disrupt the structure of collagen within these plaques, potentially promoting the breakdown and remodeling of excessive collagen. Next. So we have some studies about Ege, and Dr. Gennaro in 2015 conducted a study comparing 83 patients that received 30 injections of Ege over the period of 6 months with 81 patients that received no treatment. All the patients here had acute Peyronie disease, and they were followed for 12 months. Dr. Gennaro observed a curvature reduction of 9 degrees and a plaque reduction of 93%. In an anonymized study by Dr. Kochi in 2020, intralesional injections of Ege were compared with intralesional injections of verapamil in men with acute phase Peyronie disease and showed significant improvement of pain and curvature. Finally, in 2021, Dr. Kai conducted a randomized clinical trial comparing oral administration of Ege combined with intralesional injections of Ege, and it found that to be superior to intralesional injections of Ege alone, and showed an improvement of almost 8 degrees in curvature and reduction in plaque size of 3 millimeters. Next, please. So the last therapy to be discussed here will be stem cell therapy. Next. So as Tom mentioned before, next. There are three distinctive properties for the stem cells that are important for regenerative therapy: the self-renewal potential, the potential to proliferate extensively, and the ability to develop into multiple lineages and be applied into different tissues. The most common sources are bone marrow, adipose tissue, and umbilical cord, as Don mentioned. Next. So how does it work? Getting a little bit back from Tom, the stem cell mechanism of action will involve most the direct replacement of corpus cavernosum and then tunica albuginea as well, with the building block theory. And the mesenchymal stem cells can provide support by releasing cytokines, and these cytokines will have an anti-inflammatory effect, and therefore reabsorb the plaque with the paracrine theory. Next slide, please. So a little bit more about the mechanism of action. So stem cells may have an anti-inflammatory effect and immune modulation associated with a paracrine signaling and angiogenesis. So it's known that stem cells modulate the local inflammatory and immune response, and they're reducing the production of pro-inflammatory cytokines. And these cytokines are responsible for the plaque formation. So also it is noticed a reduction of infiltration of macrophages and also the production of chemokines. This will dampen the chronic inflammation associated with Peyronie's disease and prevent further fibrotic tissue formation and deposition, promoting tissue regeneration. Also, stem cells will release growth factors and other cytokines that play crucial roles in tissue repair and regeneration by promoting angiogenesis. It will reduce the fibrosis and stimulate the proliferation of local stem cells and progenitor cells. Next. So the main goal here is to cause fibrosis reduction in order to restore normal tissue architecture. Next. So what is the evidence behind stem cells? If Tom mentioned that stem cells for erectile dysfunction had only 10 studies, here we have even less. But scientists were able to create an animal model for Peyronie's disease using TGF-beta injection in tunica albuginea of the rats. TGF-beta, as you know, has a major role in plaque formation, since it stimulates fibrosis and the synthesis of collagen 3. The treatment of these rats with adipose-derived stem cells have prevented fibrosis in the tunica albuginea and purpura cavernosa. We only have currently 2 studies with human that are available. Dr. Levine in 2015 treated 5 patients with mesenchymal stem cells and followed them for 6 months. After a single stem cells injection, curvature was improved in these patients by 14 to 100% with no adverse effects. Lander in 2016 combined stromal vascular fraction from lipospirit with shockwave therapy in treated 11 patients. After 6 months, there was subjective improvement of curvature, erectile dysfunction, and in the PDQ questionnaire. I mean, the data here, the evidence here is very weak. So there is no evidence to support the use of stem cell out of a clinical trial. Next slide, please. So in conclusion, the current regenerative therapies do not provide a cure for Peyronie's disease, but the results appear to be promising and the initial studies demonstrate some benefit. But more randomized clinical trials are needed to evaluate the efficacy and reproducibility of these therapies. Also, it is necessary to define protocols to standardize treatment and follow-up for each kind of therapy, and future studies may also evaluate therapies for acute Peyronie's disease therefore avoiding a more dramatic presentation and progression of the disease. Also, the combination of regenerative therapies appear to be beneficial, and studies could evaluate the combination in future clinical trials. But at this time, all of the mentioned regenerative therapies are considered to be experimental. The European guidelines don't even mention stem cell for Peyronie's disease, but they do recommend the PRP and HA injections only in a clinical trial. So basically, we have no evidence to apply it to clinic, private practice, only for studies. Next. Thank you very much. We are open now for questions.
Thank you very much, Thiago, for this very detailed presentation about the use of regenerative therapies on Peyronie's disease. And we had more than 150 participants throughout the session, which is a great number. And from the chat box, I see that many people from India, Pakistan, and all over the world were participating to this webinar. And once again, thanks to ISSM members for their kind interest that they have shown to this webinar. There are approximately 10 questions. Let's start as soon as possible. Wellington Epaminondas asked, which protocol do you use for shockwave and the number of sessions? Tom, do you regularly use it for your erectile dysfunction patients?
Yeah, great question. So no, we don't regularly use it. We use it only on trial protocols. So currently we're using it for the combination trial. And I know I looked ahead of the question, so I'll answer kind of the next one that's on the list as well. But so currently our protocol, which you can find on NCCN, or sorry, clinicaltrials.gov, we're doing 5 weeks of treatment. So first week, it's an injection of PRP, followed immediately by shockwave. We're doing 720 shocks, and then shocks each week. And then on the last week, again, another injection of PRP, followed by 720 shocks. So in total, it's 5 weeks, 720 shocks each week.
So one session of shockwave therapy
per week, correct.
One more question. I mean, Dimitris Kajakaristou, if I'm not wrong, published a paper demonstrating that 3 times 6 sessions can be beneficial. I mean, what is your opinion? Do you think that it would be beneficial applying 6 sessions first, and if the patient is not responding, another 6 sessions, and maybe another 6 sessions?
Yeah, I don't know the answer to that. That's the reality. When we come up with the trial protocols, we have to come up with something that sort of makes sense to us and is something that patients are going to follow. Since we're not using it outside of the trials, I can't say. So, we do our protocol and then we have to do our follow-ups. So we have not offered sort of long-term sort of repeat sessions. But, as with most therapies, if you want to just use physical therapy as an example, I mean, we know that the more sessions you do and keeping up with protocols is helpful. One thing to keep in mind is, with these patients that we're treating, think about what is their underlying cause to begin with. So if there's somebody who's a diabetic and you're not treating their diabetes, this stuff is never going to work, right? You have to first fix that underlying medical problem if you're going to have any of these restorative therapies have any benefit to patients. So, and I kind of went off on a tangent, but no, we have not been doing repeat treatments for people at this point.
Thank you so much. Thiago, what about you? Do you recommend shockwave therapy to Peyronie's disease patients? And if you do, what is the protocol that you are suggesting?
So because here in Brazil is very hard for you to actually have a machine available just for pain management, I usually do not recommend shockwave for Peyronie's disease. Although I have seen some colleagues that have the machine available at the office and they'll do it. But I think it's an option, right? I think the protocol for 1 session a week for 4 to 6 weeks may not be as effective, and it could be intensified, but maybe some studies could prove that, because I think it could be working as like a physical therapy, and then doing only only once a week may not be enough, or maybe doing for a longer period of time during the acute phase. I think the only doing for 4 to 6 weeks is a short period. And I do understand why trials do that, because it's very hard to get the patient there doing it for 15 to 30 minutes, and you have like to do it for 90 patients. So logistically, I understand, but I do believe that maybe doing it for the acute phase, during the whole acute phase, or during the whole pain of the patient would be better. But I have no actual data to prove that.
Dr. Lima, if I could ask you really quick, this is great discussion. I mean, so you say shockwave can be indicated for a patient with Peyronie in the active phase when they have pain, correct?
Yeah.
So that's the only indication. I mean, how about the patients? I'm just asking the question of how about a patient with complex deformity, hourglassing, there's a multiplanar deformity, there's shortening. Do you also offer shockwave in these patients?
No, I usually do not, especially if they are not in pain, but I do offer traction or vacuum therapy. I do recommend them to be closely do a follow-up, because these patients will have severe complications from the disease itself with penile shortening. And I believe that doing especially the vacuum therapy to preserve a little bit of corporal cavernosum tissue is interesting for future procedures itself.
And just one minor comment, that's the only indication in the European Association of Urology guidelines. I mean, acute phase pain, and in such cases, we did recommend using shockwave therapy, not for the curvature, not for the plaque size, just for removal of the pain based on the clinical data available. Charles Runnels provided a small review article here stating that saline injection into the Peyronie plaques should not be considered as a placebo, and even the saline injections and probably microtunneling can be beneficial in reducing plaque size and maybe decreasing the curvature degree. Thiago, any comments on that?
No, I 100% agree. Especially at the beginning when we used to do collagenase injections without tunneling, we saw a big difference when we start tunneling it. So I think the mechanical trauma of the needle will also create an environment for the release of cytokines itself. And maybe with the expansion with the saline injection, it would explain some results. But the comparison here with the saline showing that, for example, PRP had a statistically significant improvement, may show that PRP has additional effects to the mechanical trauma of the needle and the expansion of saline.
Excellent. So if, to sum up, you are suggesting that it's not the PRP or saline or verapamil or hyaluronic acid which does the job. Actually, the tunneling, maybe inserting some needles to the plaque is the trick.
Of major importance. And I think once you do the tunneling, you get more surface area, and then you can use the drug in a larger area, and it will affect the plaque with giving us a better result than just doing one injection.
Excellent, thank you. As you guys know, there are more physical therapies for both erectile dysfunction and Peyronie's disease. What are your opinions about RF, radiofrequency? Tom?
Yeah. So I don't want to speak too much on RF because I really do not consider myself an expert on it because I have no hands-on experience.
No one has.
Yeah.
You are not the only one.
So, I mean, what I'm going to tell you is just, what I've read about it online, which is probably, it's supposed to help with collagen remodeling. And we know that collagen is a big component of the penis and is involved in erections. So, there's not a lot of data yet out there. I know Faisal Yafi is trying, I think it either has a trial going or is starting one. So hopefully we'll have some data on it, but I think it's going to fall into this category of there may be some benefit without a lot of negative side effects.
Yeah, I 100% agree with Tom. I think once we have more robust results about RF, I think would be interesting even to compare results with the other therapies. But I also do not have any experience with RF for Peyronie's disease.
Thank you so much, Thiago. And the king of Peyronie's disease, Dr. Levine, is with us, and he made some comments about the data on PRP treatment for Peyronie's disease. He is asking whether the curvatures are measured objectively with a goniometer, and what were the reductions in the curvature degree. And he is warning us about the use of such treatments, and he is underlining the fact that many doctors, unqualified doctors, are doing such treatments just for financial purposes. And he's congratulating Thiago for his conclusions, and we are conveying the message.
But getting a comment on that, yeah. So I 100% agree with Dr. Levine. Statistical difference and clinical difference are very different. And having a patient with a 30-degree curvature and an improvement of 30% will give us 9-degree curvature. So maybe in this case, the patient itself will actually not notice big difference, but is statistically significant because they used a percentage measurement. But yeah, most studies actually use the goniometer. But I 100% agree. I mean, the use of degrees should be like standardized. And this is something that Tom was talking about. Like, if you want to compare studies, it should be using the same measurements. And because then you can see like, oh, you have patients with Xiaflex that has 17-degree improvement, and comparing to a patient with PRP study that also have 70-degree improvement. So these studies are actually kind of comparable. But once you only use percentages, then you have to go to each patient and see, oh, this guy had 30-degree, but only improved 10%. And then you see it's not significant, but maybe for a guy with a higher curvature, improving I don't know, 20 to 30% will be more significant than from a guy with a lower curvature. But
Thank you so much.
100% agree.
Dr. Masterson, how many areas are you targeting with Shockwave for erectile dysfunction? You mentioned about it, but it would be nice to summarize it once again.
Yeah. With our study, we're basically targeting, the ventral surface of the penis. So, and that's just the probe with the shockwave generator that we have. It's not intended to direct at the perineum. So, if you look at the different probes, some of them are circular flat, and they can be targeted to different spots within the penis. Ours is basically almost like a hot dog bun that the penis lays inside of. So ours really does just target, the ventral surface of the entire length of the penis.
I guess a question for you, both of you, if I may, Ege.
Sure.
Regarding the delivery of the shockwaves, if you're dealing with a patient with ED versus PD, is there any way of difference of how you hold the probe, you deliver the shocks? I know you've mentioned the protocols of each condition, but can you tell us, is there any major difference between how you deliver the shocks to the patient and how many shocks for each patient? Or maybe a patient has both. Can you comment on that?
So yeah, usually when you deliver shocks for erectile dysfunction, you're aiming for the whole corporal cavernosum because you need the effect on the whole thing. But for Peyronie's disease, I think you're more localized. The protocols, they delivered the same amount of shocks, I think it's 2,000 if I'm not wrong. And the sessions were once a week. So for erectile dysfunction, I've seen some clinical trials with longer sessions, longer periods of treatment. But for Peyronie's disease, the current studies showed for 4 to 6 weeks.
Excellent. Thank you, Thiago. For Dr. Masterson, about your clinical trial, once you start doing PRP, do you find any impact of PRP in decreasing the dose of PDE5 inhibitors? I mean, did your experimental treatment was associated with a decrease in the PDE5 dose?
Yeah, so I'll give you a longer answer. So, because a lot of people ask about why we allowed patients on PDE5s compared to the others. And this was truthfully just a recruitment strategy. For any of you who have tried to do any of these prospective trials, asking somebody to stop a therapy that they're getting some benefit from is really difficult. So we kept patients on their same dose and basically had to take their word that they were staying on it. We asked them at 3 months whether they made any dose adjustment modification. And the truth is, patients really didn't try to make any adjustments. Another reason why we kind of had to take their word for what they were doing is, unlike, say, insulin, where you can check to like was it the C-peptide, we have no biomarker to say whether or not a patient is or is not taking PDE5. So, I would caution that in studies where patients were asked to stop taking their Cialis and Viagra, there's no way of knowing they actually did that.
Thank you so much. I guess, okay, another question about radiofrequency. Dr. Levine also provided beautiful information about the dry tunneling, which is important for Peyronie's disease, and he's underlining that verapamil is cheap and easy to administer and safe, and also often covered by insurance companies. I think we came to the end of the questions which are related to regenerative medicine in erectile dysfunction and Peyronie's disease. And I would like to thank both speakers for their excellent summary. And Dr. Raheem?
Ege, just one of those, a couple of, I think one more question. Dr. Love, did you see that question about, I'm not sure if you covered, but differences in shocks delivered dorsally, laterally, and ventrally? Any comments really quick from the panelists?
Tom.
Yeah, go or Tom. It's about the way the shock is delivered.
I mean, I only can say by the experience that I had in Brazil with the, I think we applied it laterally, but I'm not sure about if there is any difference. I will actually need to look into it. I have no evidence that will change anything. I mean, anatomically, if you do ventrally, you'll be dangerous because of the urethra. But maybe dorsally or laterally, I don't know. I'll leave it to Tom.
No, so actually, I'll stand corrected. We were on the ventral surface, and that's because the urethra sits between the two probes. I really don't think that there's going to be a substantial difference. I mean, you're targeting, the corporal spongy tissue. So the depth of penetration for this is not substantial, but you are going to be getting through the penile tissues. So I don't think it really matters if you're applying it dorsally, ventrally, laterally, as long as your sort of like midline focuses into the penis and basically headed towards the cavernosal arteries. I think you're going to get an effect from it. But this is mostly, we don't have animal studies. I'll tell you, if anybody out there wants to do it, the way to do this is you have to take penile tissue biopsies. And if you can find a patient willing to do it, awesome.
And Tom, also on the ED, Dr. Zahran from Egypt asking, is there any studies comparing the machines, efficacy of machines on ED outcomes?
Great question. As far as I'm aware of, there are no head-to-head studies. Most places are just going to have, one hammer, and they're going to use that hammer. They're not going to buy a second one because it is an investment to get the machines for sure.
Got it. I think that's it. There's more question. I feel like we should do another webinar covering the regenerative andrology, sexual medicine. Thank you, both of you, and thank you, Dr. Serefoglu, for moderating. Great session today. I'd like to kind of close up the webinar. We are 2 minutes ahead of schedule, so I want to respect every time around the world. So I'd like to see the next slide, please, Lillian, if I may. Okay. So as I told you, this is the last webinar of the year, and stay tuned for next year, January 2024. We have a whole list of great, exciting webinars talking about different things on sexual medicine. So please stay tuned. This is, again, a webinar going to be advertised in advance, but we're going to focus on the great meeting we are planning for the ISSM, the Middle East Society of Sexual Medicine, in the 24th World Meeting on Sexual Medicine in Dubai, December 15th to the 17th. So please register, attend if you can. I know it's far out in Dubai, but I think we're all excited to go there and meeting with all friends and mentors and leaders in our field. So with that, I'd like to thank you all, and till then, take care.
Thank you so much. Bye-bye.